Hey there, welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Hi, Megan.
Good morning, Roxy. How are you today?
Doing well. Did you survive the snow and the blizzard and the Nomageddon?
Oh my goodness. Yes, we did. And you guys got a lot more than we did. So I'm just glad to be back in a routine. It's funny, last week was the first week back for kids' school, and then obviously all the snow days. And then this week is a regular week. And then the kids informed me that next week they have Monday off for Martin Luther King Day. And I was like, oh yeah. So I just feel like we can't seem to get going. But all good here. And we are super excited for this episode today. We are going to dive right into introducing our guest. And maybe at the end, Roxy will circle back to our Tell Us Something Good. But we are super excited. We have Mr. Bill Taylor on our podcast today. And so Bill Taylor has been a physiotherapist for almost 40 years with over 25 years experience in the treatment of pelvic floor dysfunction. He is a widely recognized therapist in the UK and internationally as being one of the leading pelvic health physios and one of the few who specialize in male pelvic floor dysfunction. This is, for Roxy and I, so exciting to have Bill today and be able to talk to him. It's kind of one of those pinch me moments because we met Bill at PelviCon this last year, and just such an amazing speaker and educator and has so much knowledge that we are just so gracious to be on the podcast and humbled to get to be able to speak with him today. So we'll let him tell you a little bit more about himself. But he has, this guy, he has contributed to a chapter in the Chronic Pelvic Pain and Dysfunction textbook entitled The Effect of Sports and Exercise on Chronic Pelvic Pain. He's also compiled the chapter on pelvic girdle assessment and the text Neuromuscular Assessment. He's taught widely in the UK, Europe, Scandinavia, Israel on male and female pelvic health. Amazing. He is one of the few UK-based physiotherapists to work full-time in male and female pelvic health and is the clinical director of his own clinic in Edinburgh, Scotland. So that's the other thing, guys, is like this guy is coming today on the podcast from across the pond. Super exciting. Additionally, he has worked with the Scottish Ballet and the Scottish Dance Theatre for over 20 years. He has developed a full-time physiotherapist service to the National Ballet, after which he continued as a consultant physiotherapist for a number of years. So as you can just hear from this is going to be a packed full episode of amazing knowledge. And today he is going to be talking to us about erectile dysfunction, which is often a diagnosis that is not commonly talked about. So to have him share his knowledge is going to be such a gift. And we hope that everybody takes something away from it. And we hope you enjoy this episode. All right. Well, Bill, thank you so much for being here. We're super excited to learn from you. We'll let you kind of lead us in and tell us a little bit about yourself. We'd let everybody know that you're from across the pond, but tell the listeners exactly where you're located.
Well, thank you very much for inviting me along. It's very cool to be here. I'm based in Edinburgh, Scotland, which you all know is very beautiful, and you especially know that, Megan. And I live in the capital city, which is, I'm very lucky to live here. It's a beautiful place, and I've been kind of tucked away in my background's a little, well, you probably heard, a little convoluted. I've done quite a lot of different things. I had absolutely no idea I would end up being a pelvic health physiotherapist. And if you'd told me 40 years ago I'd be sitting here having a talk to you about erectile dysfunction, I would be saying, what? No chance. But here I am. I have to say this because I think it's just good to be open. I'm obsessed with pelvic health. I think that we need to really, I think a lot of pelvic health physios are, which is the the nice energy you get, especially having met you guys at PelviCon, and the whole PelviCon thing was just amazing. So really, I mean, not that I needed much spurring on, but it really remotivated me and got me interested in what I want to do. So I have a clinic and I do 50% MSK work and 50% pelvic health just to keep myself a little bit sane, and also to kind of keep my brain working in the MSK mode. And because I think that there's a huge connection and crossover between pelvic health and MSK in the way I work. So I don't like to separate it. So just so I keep my skills honed, I keep doing both. I'm getting a bit old, so I'm thinking maybe I'm going to slow down on the MSK. So yeah, 95% of my pelvic health caseload is now male. And that really is because I have 3 other physios in the clinic that treat the female women, the women.
Yeah.
And so it's kind of, that it just works out well for that. I have one other physio that will treat males, but a lot of physios don't want to do it, and that's absolutely fine. Yeah. So I suppose my background really is I was really a pain physio, chronic complex conditions, career-ending sports injuries, that kind of stuff. That it was all the complex stuff that no one wanted to see that I was interested in. And so when I started looking, I came at pelvic health from that point of view, that the very first place I went was pelvic pain. So I wasn't interested at all in incontinence and erectile dysfunction. I thought that's got nothing to do with me. I'm an MSK physio who happens to be treating pelvic pain.
Yeah.
But what kind of happens, of course, is you're not just treating a pelvis or a penis or a vagina or an anus. You're treating a person. And that person saying to you, I have this erectile dysfunction, but I also have pain, and I'm taking opioids, and I'm doing this, and I'm constipated. And I suddenly thought, wow, this is bigger than just what I'm doing. And I met some amazing people along the way. Ruth Jones was probably my very, very first mentor. And she did quite a lot. She did her PhD at Stanford, and she looked at pelvic floor ultrasound and imaging, pelvic floor movement. And then there's too many amazing women in pelvic health to even mention. The guys, Stephanie Prendergast and Elizabeth Rummer from California, I met them probably, I don't know, maybe 15 years ago, maybe now. And so I started looking around and seeing what was out there. And then in the last 5 to 10 years, I suddenly had to become interested in erectile dysfunction and incontinence because they're coming in the door fast and furious. And I kind of felt as well that they were all taken care of. I thought that the pelvic health physios were sorting them out. And what I kind of discovered was that I suppose I had never been to, if you like, a traditional pelvic health educational pathway. I had done lots of modular courses and joined them together and critically kind of analyzed them. But the whole idea of prescribing Kegels to everybody and that was going to fix everybody just didn't ever make sense to me. It seemed nonsensical, especially when guys would say to me, I leak when I stand up, I leak when I squat, I leak when I climb, I leak when I run. And I would think, well, yeah, okay, so we have to look at the function. We have to look at what you're doing. So it's not this case of squeezing, and if you're not doing it, squeeze it a bit harder. And if that doesn't work, do it more. And also, I come from a real strength and conditioning background. So I kind of thought, am I missing something here? Why do we take the pelvic health muscles and make them something mythical, something new? Why don't we put them up here and worship them as if? And so I think we have obviously an awful lot of evidence that shows that pelvic floor muscle training really, really works for incontinence and for pelvic floor dysfunction.
Yeah.
But if you look at the numbers, if you look at the numbers in the papers, it's 40%. So what's happening to the other 60? What's happening to the other crowd of what's happening to, do we just say, well, you don't fit with our results too well, so we're just going to leave you, right? And there was a kind of I think it was Claire, there was a physio, an English physio, she put something on her Insta the other day and it said, research is important, but then there's actually reality. And actually the person in front of you, what they're doing. So I think that I got really interested in erectile dysfunction because I realized it really affects men right across the age spectrum. Mm-hmm. And I think the numbers are something like I think I read a paper in 1999 that said, a 1999 paper that said there was 150 million men worldwide with
Wow.
erectile dysfunction. And in 1999, they said they thought that was going to double by 2025. And here we are. And actually, if you start to look at the numbers, it's getting pretty close to that.
Wow.
Wow.
But it's really difficult to determine how many people have ED because men don't, it's into that whole holistic kind of, it's about the person. Men aren't very keen to say, guys in the pub, they don't say, oh, well, how are you doing? Oh, I hurt my leg at rugby. What did you do? I went in for a tackle and I really hurt it and it's bruised and swollen, but I'm doing the physio and it's getting better. But they don't say, oh, last night I was having sex with my wife and do you know what happened? It was just 50% hard, man. I mean, honestly, what am I going to do with that? And they go, really? Yeah, that happened to me too. What did you do? That conversation really often doesn't happen. I think perhaps it's getting better in that I'll tell you a funny little story, and my son will absolutely hate me for telling you this, but it's one of his mates, a very, very good mate of his, and I hope he never sees this, otherwise he'll probably come after me as well. He has a little bit of erectile dysfunction. He's quite young, which is again the thing I see in the clinic. Is people assume it's like prolapse is something that happens to older females. Erectile dysfunction is something that happens to elderly gentlemen. It's not. It happens to young people as well. And he's kind of 18, and my son's sitting in the car with me. I'm driving along, and so as he's got a bit older, he would usually talk to me when we walk the dogs, or he'd talk to me at the gym because then I'm a captured audience. Now he talks to me when I drive him to places. So Peter has erectile dysfunction, and I'm still driving. I'm thinking, I'm the pelvic health physio. I listen to patients tell me this all day, but it doesn't usually come from my son about someone that he knows. And I'm like, okay, well then tell me a bit more about that. And is it, what's happening? Can he get an erect? Does he find women attractive? Is he attractive? We had this whole conversation, and I said, he's got some stuff going on there. But it was an interesting thing for me because his friend was sitting in the back seat, and we'll call him George. And George said, oh yeah, you know what? We think he's kind of psychological. We think he needs to sort himself out, and I'm thinking, oh, and I kind of dropped them off. And I thought, wow, I honestly don't think I would have had that conversation with my father. And I honestly, these young kids, and I thought, so maybe there's hope that men are getting more used to talking to each other. I think the whole gender awareness thing has changed things a lot. And so it used to be, you were straight or you were gay and you would talk about that or you wouldn't talk about that. And now it's kind of, everything is just so much more kind of easy. And I know not for everybody, but let's hope that maybe that's kind of how it's going. It's interesting when I see guys in the clinic, have conversations with them, and even I'll say to them, so how's your erectile function? And we all think, right? We all think everybody's having loads of sex, and we're not. Okay, everyone thinks everyone around you is having the most sex they ever can have, and in actual fact, most people aren't. Most people are too tired, too knackered. They've got stuff going on at time. They've got their stress, their work. There's a whole bunch of stuff that affects all of that. And sometimes guys who are quite young, early 60s will say, well, I'm not having sex anymore. And I'll say, can I ask you why? Well, it started because initially it was sore from my wife, so we stopped.
Yeah.
So then we didn't really know what to do about that. I didn't really want to be there. I didn't want to be part of that if it was going to hurt her, so we stopped doing it. And then I just stopped. I kind of lost interest a bit, and our relationship changed, and we became kind of companions and friends, and we just decided it wasn't important for us, which is, absolutely fine if that's the choice you want to make.
Sure.
But I think, I did have an 82-year-old Church of Scotland minister come to see me with erectile dysfunction, not from prostatectomy, just because he aged probably. And we got him sorted, and his wife I think she was 84, and the pair of them got back to having sex.
Oh, I love that.
And then drove a whole like 40 minutes to see me, to give me a bottle of wine, to go, thank you so much.
Oh, that's so great.
And I love the whole thing about we should never judge, either way. Either way is fine. If you don't want to be having sex, that's fine. But if you do, then that's fine as well. And let's see if we can try and make that happen. So yeah, so I think, I guess in the clinic, what I see is I see a lot of young guys kind of, it started during COVID. So it started, for
Okay.
me, it was really people being isolated, because I think the thing about erections is they're not about your penis, they're about you as a person. They're about all of you. They're from your head to your toe. It's not about this organ that sticks out of your pelvis that's going to do this thing,
Yeah.
and sometimes it might be, for guys will masturbate and use erections and ejaculation as a stress relief. But that's a very different thing to using it as a kind of a intimacy moment or being connected with your partner in any way. And I think it's funny when you start looking at kind of papers talking about ED, often it's very patriarchal, it's very male orientated, and it's very cisgendered. And it's very kind of like, it's an inability to achieve or maintain an erection. It just says to allow sexual intercourse.
Yeah.
And I'll think, well, there's an issue straight away because you're making an assumption and a judgment that that's what people want to do. You're making an assumption that they're in a straight relationship, that they're AMAB or AFAB, or they participate in different sexual activities, where we can't really do that because everyone's so different these days. And I think in the past, if you were different, you kind of kept it to yourself. You didn't tell anybody, and you didn't talk about it. Whereas people now are more open to talk about it, I think. So I think we need to, think about it in this kind of broader spectrum. And I think that's what I try to do in the clinic. Is I think someone said to me the other day, early career physio, and he said, so how do you talk to someone about this?
Yeah.
And I said, well, it's a good question. I said, I try not to talk to them about it. I try to give them the space to talk to me. So I try to sit down and say, hey, so what's happening? Tell me what's going on. And I said, and if I really, and sometimes they're just so keen to open up to you.
Yeah.
And I think sometimes we have like a questionnaire that will talk about erectile dysfunction. So that's the very first kind of nod to them that they're able to talk about it, because maybe talking about it and listening to them is the most important thing, I think, because it's all the background stuff of, if your relationship with your partner is not good, and me making your penis work better is not necessarily going to give you the best sex life. You're going to, a whole bunch of other stuff you're going to have to work on. You can't just go and go, hey, we're not getting along well, but look what's happening now. Let's get on it. It's
That's right.
So I think, and it's really interesting because there was a study, I think it was Massachusetts aging study, and it was like the late 90s, early 2000s, I think. And it said something that 52% of men right across the age group had some form of erectile dysfunction.
Wow, that's high.
That's stunning, isn't it? And it's like, if you're like at 70, it's 3 times greater than at 40. So as men get older, it gets worse. I mean, I thought maybe what I might do is just talk a little bit about how I think about I think about erectile function on a kind of like from a medical point of view. It's a really complex, like neuromuscular kind of event, and I think it's really about so there's a vascular component, a sensory component, an arousal component, a more kind of cortical, higher level thing that's going on, as well as local hormonal issues, hormonal changes. And then you have the muscular component, which is really the bit that we're kind of interested in. Except one of the big things that has the biggest effect probably in erectile function across the spectrum is lifestyle and how you choose to live.
Yeah.
But ultimately, from a physiological point of view, you're looking at the degree of contraction or relaxation of smooth muscle that determines the stiffness, because that determines how much blood stays in the penis or doesn't get in. And it's this balance that's between the contraction and relaxation by central and peripheral mechanisms. And we've got the central nervous system, we've got the peripheral nervous system, and then we've got the vascular kind of issue, cavernosal system in the penis. And the central nervous system, obviously, we talk about it as if it's separate, but it's absolutely integral to everything that's going on. So we're having this conversation, and just to understand it, we break it down a bit and make it seem like it's something separate. But you've got visual, auditory, cognitive, imaginative, if you want, tactile, olfactory. You've got all these things. And sometimes I think, well, where do you even start?
Yeah.
Like and I think, there's some clues there. So I got this idea that during lockdown, I had lots of guys. So I kind of I'll go away and then come back to the same topic, but we're back to lockdown now. And during lockdown, I had a lot of young guys that were watching a lot of pornography. And I say this, they were watching too much pornography. I don't know what too much pornography is, right? 17 hours a day seemed like a lot to me, right? It seemed to me...
That's a lot, Bill.
That's a lot. That seemed to me like, where is your life? How do you... And it was partly because they didn't get out. They probably didn't get out of bed. They just stayed in the one room. And it was really interesting. It was sometimes they were students stuck at college, or for some reason, maybe they were just in the room all day.
Yeah, wow.
What I discovered during those times was they were watching more and more porn that was becoming more and more kind of, and I hate to, it sounds really judgy to say nasty and kind of maybe violent, but that's kind of what was happening because everyone's into their thing. And if it's consensual, that's not a problem. But some of this porn, it's really, you can tell that the people that are in it, it's not just porn. It's not fair. Those women are not, they're not often there by choice. There's a whole other issue behind that porn. There's whole other things that we can talk about. And I think that's an issue. And what would be happening is that they would have to do more and more porn to get aroused enough to reach a climax. And then they wouldn't be able to reach a climax. And then they would not be able to get a full erection. And then they wouldn't be able to get an erection at all.
Wow.
And they're oftentimes, and it was a little bit connected to, there's a thing called ketamine bladder. So if they were doing ketamine as drug, social drug taking, or if they were doing MDMA, so if they were doing those drugs were having an effect on their central nervous system, their autonomic nervous system, which was having a big effect on their whole erectile function. And one of the things about olfactory and tactile things was, with some of these guys, just to mention these before I talk a bit more, I said to them, so what smell do you find? Because actually having sex is all about stimulating your parasympathetic nervous system and reducing your stress a bit and relaxing. So I'd say, so what smells make you relax? Put a candle on,
Yeah.
And then actually don't touch your penis, touch yourself somewhere, but you're not allowed to touch your genitals, and see how that feels. Kind of use almost like a sensate focused recovery for them. And I just wanted to make that point because it's not all about and focusing on the penis. It's this much, 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 much wider spread thing that you have to look at. We're not psychologists. We're physiotherapists. We're physical therapists. We do physical things. But I still think that, we have a really good understanding of the body and sensory input and how and touch and proprioception and interoception and body awareness. So I think we're kind of in a good place to sell that.
Yeah.
So I think, the central pathways integrate these inputs. And one of the things about it, when you start looking at the physiology of this stuff, is you think, I'm a little bit confused by this. I don't quite understand it. And then you realize it's because they don't quite understand it. They're not absolutely certain as to what happens. There's lots of different people with lots of different ideas.
Yeah.
And we do a general picture of what's happening, but we don't absolutely 100% know. We know that it's about sympathetic nervous system stimulation. We know it's about it. And we know that these descending pathways, they contain things like oxytocin, vasopressin, enkephalin, dopamine, and vasopressin, it's a drug that regulates blood pressure. So of course that can change the amount of blood that's going into the organ and not coming into the organ. But it's also really connected to the promotion of feelings of loyalty and emotional connection. Ta-da! So you think, you kind of go hello? It's and it's triggered by intimacy and trust building experiences. And you think, well, so I can't just make your penis work on its own. Immediately there's a chemical here that's connected to trust and intimacy. So this is about intimacy. And some guys are talking about these intimate things for the very, very first time. So it's not just good enough to say, let me teach you to retrain your pelvic floor muscles and go away and do that. And that will just be, you'll work, because the guys I see have been doing Kegels for 6 months, 8 months, 9 months, and they're not any better.
Mm-mm.
And I think it's partly because they're not connecting with this hormone system that they need to be connecting with, really.
Bill, real quick, just with that, just some low hanging fruit real quick. Like, what do you, like you told that guy, don't even touch your genitals, where would you even start? Especially some of the younger guys who maybe haven't had a great trusting relationship yet because they're younger. Like, what's your recommendation on that? I think that's fascinating.
Yeah, it's a really good question. I think one of the things I'd say is this: I really practice trauma-informed therapy. And what I would say is, with everyone that's in front of me, I have a global position that I take that everyone's been traumatized. So then I don't have to figure out who has been. So it's a bit,
I like that.
It's a bit like in the 80s with HIV. You just took global precautions. So you take a global trauma-informed process and you just kind of listen and you try to figure out what they think about what you're saying, what you think they might be up for. So if I want to get away, if I don't want her to be touching his penis, but I want to change his autonomic nervous system. And I kind of learned this really from Jilly Bond, I think, and I stole some of Jilly's ideas and applied this to my erectile dysfunction people. And Jilly's a great physiotherapist in the UK that has done lots of, she's a doctoral researcher, and I work with her in the Pelvic Pain Network. And she said, you get people to work on their flight or fight system. So young guys are dead easy. So I get them to stand up, a bit like maybe what I talked about at PelviCon, and I get them to box. Then I get them to run away, and then I get them to freeze. So it's got nothing to do with sex, except it kind of has. And I'll talk about that in a little bit, why I think that does have something to do with sex. And then what happens is they start to get a connection to the autonomic nervous system feelings that are connected to sexual arousal. Because although because sexual arousal is a little bit of a balance, isn't it, between sympathetic, parasympathetic, sympathetic, parasympathetic. And you can have very, if you like, slightly more sympathetically driven sex or more parasympathetically driven sex. And it's the balance, if it goes too much one way, then that has a hormonal change and that makes it not work. And that's why guys, I don't know what happened. I was like, I was fine. I had a normal erection and then suddenly it stopped.
That's such a good point. Yeah.
So with those guys, I think it's like, first of all, we know that there's a lot of evidence out there for patient-therapist alliance. So really, really, and I think in pelvic health, it's just so important to develop that absolute trust and alliance with your patients. I have 3 things that I do with them on the young guys especially, well, actually probably all of the guys, on their first session. They've often been sent to me because everything's been tried and they've been told there's nothing that can be done. And so there's 3 things I'll do. I'll say, okay, I'm going to tell you what I think's wrong with you. And it might not be a diagnosis. It might be a functional assessment. And I'll then say, I'm going to tell you what we're going to do to mend that. And I'm going to try and tell you how long that's going to take to get you better. And I've never once mentioned you're not going to get better. I avoid all nocebic chat because they've been told that they're stuck with this. I set that up. And then at that point, I might, depending on how I feel our alliance is going, I might push that a little bit. And then further down the road, I use a lot of sensate focus stuff. So I'll say to them, look, I want to see if you have you explored with a partner or with yourself? Do you like being touched at the back of your knee, the front of your elbow, in your armpit? How are your nipples? Do you like being touched around your bum or your anus or your toes? Or what is it that would turn you on separately from your penis? And they frequently go, I have no idea, because they've never looked, because they don't go beyond the penis. And I'll say, because we all know that the pelvic floor works automatically. So what we're trying to, if he goes straight to the penis, the whole focus is there. Immediately, it's like, if this don't work, this is horrendous. So if we can do something else to get the whole chemical cascade, the vasopressin, increase blood supply, change the smooth muscle contraction without him actually thinking about it. And that can sometimes come along with put on a candle you like the smell of. Guys are very metrosexual. They burn candles. It's fine. It's not considered that they go and do. I do a little bit of, not a lot of education, but a little bit. And I say, that you've got chemicals like your enkephalins that are part of your body's stress response. So we need to reduce that stress response because it gets dysregulated, it gets mixed up, and we want it, and it increases your sympathetic tone, and that's you running away. So so let's just say from an evolutionary point of view, you're in the jungle, you find a female partner that you're going to have sex with. And I said, you have to remember, all of sex started out about it's a sperm delivery system. That's what it was. And actually, we've made it something different. We made it about connection, intimacy in relationships, but it was actually about the survival of the human species. And you had to do it really quickly and then run away, because if you didn't, you would be eaten. And if you hung about, you'd be eaten. And actually, it's funny because someone said, is that true? I went, I really think it is. And I went and looked up, and there is some anthropological theories around that I might try and touch upon as we go on. But I say to them, like we need to talk about your whole system. We need to talk about you not being stressed. Because the problem is, as soon as you get anxious about your erectile function not working, then your erectile function isn't going to work, because it's a self-fulfilling prophecy. So you want to get them away. So I think that's, for me, get them away from their penis, really. And I mean, you can use their testicles. Sometimes they're really comfortable with that because that's something perhaps they've tried before. And I think the other thing is good to mention that some of these guys who come when they're in pain, opioids mimic enkephalins. So, and they can really, really, really reduce like hypothalamus pituitary expression and reduce testosterone over a long term. So chronic use of opioids can have this other like different effect on and what we're really trying to do is get oxytocin and dopamine and all of that good stuff. We want like serotonin. We want that good stuff into here. And that's sometimes quite a change from them, because if they've been having fairly kind of, aggressive is not really the word, but let's say aggressive sex with themselves, with porn that's quite aggressive, that doesn't induce oxytocin and dopamine. So we want to get that to happen. And then I think, we've got kind of, you kind of look at them, and I'm a big kind of like whole body thing. I'm a whole body thinker. And I think, well, if you look at the peripheral nervous system, we have like in the spinal cord, we have two erection centers for one. I think maybe, for want of a better word, let's call them erection centers. We've got kind of E1 to L2, sympathetic outflow pathway. We've got sacral S2 to S4. We've got parasympathetic output. So I reckon, and it connects with the genitourinary tract via the pelvis, with the pelvic and the cavernosal and the pudendal nerves. So there's a spinal connection, a spinal nerve connection. And these guys, when you see them, they're a bit stiff. They don't move particularly well. They've often they think their testosterone's low, so they're often battering themselves at the gym. So their core's really rigid. So they're actually, they're core rigid, not core flexible, and not core strong, but they're just rigid. They've got all of this stuff happening. So I always say to them, I need to get your thoracic spine moving. I need to get your lumbar spine moving. I said, because when we get you back to sex, you need to be able to move your hips and your spine to have sex. So there's no point me making your penis and pelvic floor better if the rest isn't.
if you can't move.
Yeah, exactly. If it can't move, then you're gonna be boring. Okay, it's not gonna work.
I like that too, though, because getting people to understand the importance of the spinal input for those functions. Sometimes they don't see it. They're like, why are you working on my back? Like, I want my penis to work. And so to even be like, listen, for you even to have sex, your back has to move.
Well, I say to them, I'll say to them, so you've been doing Kegels for 9 months. How's that working for you? And they'll say, yeah, not really. It's like nothing's really changed. All right, fine. I said, so tell me, just describe to me before this happened, how did you have sex? And they go, like, because no one's ever asked them, right? And I'll say, well, okay. I said, I wasn't necessarily expecting you to tell me, but how you didn't have sex was lying on your back with your knees bent up, squeezing your pelvic floor.
Yeah.
That does not look like sex, does it? I said, did you ever have sex in that position? And was sex for you a voluntary contraction of your pelvic floor? No, it wasn't. You didn't think about your pelvic floor. You moved your hips and your spine and your legs, and you moved your upper body, and you got yourself into positions that both you and your partner liked. Whatever you were doing just worked for you. I said, so I said, it's like if you came to me because guys they've always had some kind of sports injury. So you come to me with a sore knee and you say to me, and your knee's swollen and it won't bend and the muscle's sore, and you say to me, I want to go running. And I say to you, okay, just jump on the bed. And I say, yeah, so you've got a ligament injury and there's some effusion in the joint. So I want you just to squeeze your quadricep really hard. Good. Right. I want you to do that 10 times a day. And I want you just to keep doing it and come back and see me in 2 weeks, which is what we really do to pelvic floor patients sometimes. So send them away. And he comes back and he goes, yeah, it's all right, but it's not much better. And I'll say, well, show me a contraction. Oh, that contraction's a lot better, because how many times have they been told their contraction's a lot better?
Uh-huh.
Yeah, but my symptoms haven't changed. You're fine, go running. That would be negligent of me to do that. I would say I'd have to put in a graduated return to running program. I'd have to strengthen you up. I'd have to make sure you got full range of motion, that you could functionally do the things I want you to do. Plyometrics, loading, coordination, like proprioceptive stuff, all of that. And I don't think there's any different from the pelvic floor. So with these guys, you're like, and you kind of get that a little bit. The psychogenic thing's really interesting, I think, because I find that especially in younger men. The older guys, not all, but a lot of the old guys are sometimes kind of a bit okay with it because they maybe had some sex during their life, and they kind of there's also that. It's a bit like women being told that once they've had a baby, they're expected to leak, and that's normal.
Yeah.
Old guys are expected that their erections go away, and that's normal.
Yeah.
And they go, well, all right, yeah, I was talking to my mates at the golf club, and we're pretty much all the same. So hey, I'm in the tribe. This is my crowd.
Right.
But I think I see probably 50, 60% of the people I'm seeing are probably under 30. So they've maybe not had a lot of sex, and they've maybe not had a family, and maybe they want to have a family. And I think that's the other picture, the whole kind of, if you like, biopsychosocial kind of idea around that is that they suddenly think, I might never have the life that I thought I was going to have. I might never have that wife and the children and all of the things I want to do. And of course, just having erectile function doesn't guarantee that, but at least it gives them an opportunity to try, doesn't it?
Yeah.
The other thing that I find is I see more people, younger people with diabetes. Like, it seems to be like a growing trend.
Sure.
Diabetes, cardiovascular disease are the two major kind of risk factors. And patients over 50 with diabetes or cardiovascular will have a 50% chance of getting ED. Especially, and it's secondary to vascular disease. And we know that if somebody comes to you and erectile dysfunction is the thing they present with, and there's no other reason why they should have it, they have to have a cardiac consult. They have to be sent to their GP, and they have to be worked up for a cardiovascular disease, atherosclerosis.
Yeah, absolutely.
I love that old term that we don't use it anymore, but hardening of the arteries. I love that. It's such an old-fashioned term, but I quite like it because it is that kind of idea that everything's connected. And because the small vessels in the penis are so kind of sensitive to those changes, that's kind of where it shows up first. So it can also, not only can it be kind of helpful for their sex, but it can be helpful to keep them alive, because it might all be the first time. I had a guy the other day come into the clinic with tender Achilles problem, and he's about 60, and we were having a chat, and he said, yeah, I might come back and see you because I see you do erectile stuff, and I'm not so good in that department. And I said, okay, that's fine. Yeah, I said, saying that, I said, are you okay? I said, are you generally well? Like, and can you walk as far as can you walk with your wife at the same pace? Can you go as far as her? Do you get palpitations? Well, I get a bit sweaty, and I think I'm a bit out of breath walking. And he's just had open heart surgery.
Wow.
Last week, on the basis of me saying, you should go get that checked, because so it doesn't happen that often, but
yeah.
It's tender Achilles problem. Oh, I've got some ED. I didn't even assess it. I said, let's get you checked out anyway, man. Let's see what happens. And then his wife's going, thank you so much. That was the best advice. So, we're in a kind of a prime position when we're seeing these guys to kind of promote that kind of preventative stuff.
Can I ask you a question real fast? When, you were speaking earlier, just kind of about when you're seeing these fellows, and I think a lot of men are just kind of very unsure about too, like if they have to have internal work done, and obviously consent is always there. So with these guys, I mean, applying what you're saying, because we see that a lot when we're treating women as far as like nervous system goes, and we have to address all of that. But there is definitely, I know, more hesitation with male patients on internal work. Have you gotten to a point where, because you see those people where you're like, I can tell you what an internal assessment's going to say, but how much do you do internal with these guys, and how much because I think sometimes that's shocking to people that we can actually do quite a bit without doing that, but also there's value in internal.
I agree. I mean, I think, so I'm a bit conflicted about it sometimes, because I feel that so every patient I see is like an N=1 case study, and I'm gathering data. And I want to get that data, and I want to produce my hypothesis, and then I want to get my null hypothesis and reject it. And if I can't reject it, I've got to accept it. So I sometimes feel, although I'm getting over it a little bit, I sometimes feel when I haven't done an internal, I don't have that data that really confirms what I think's going on.
Yeah.
So what would I say? I say to guys, so oftentimes I'm like a tertiary referrer, so it's a little bit different for me, because by the time they come to see me, they're done.
Yeah.
If I said I need to put my whole hand up there, they would say, that's fine, just do what you want. But because I do see guys that I can tell immediately the fear about this idea of having an internal. It's written all over their face. You can absolutely tell who it's going to be. And sometimes as you develop that patient alliance in the first session, that fear goes away.
Yeah.
So we have a few things. So and I don't know if this is, I'm not sure whether this is the best way to do it or not. They sign a form to consent for physiotherapy generally. So that's just for me to talk to them and get them in the room. If they need to have a perectal exam, they sign a separate form for that. And if I go ahead to do that, I'll say to them, so you've signed these forms, but I want to have a chat with you. I said, because what's going to happen here, you're in control of all of it. So you decide what happens. So if you don't want an internal, you don't need one. I said, you don't have to have one. I said, and there's stuff we can do. We can still work with you. We can still work towards making you better. And they'll often say, yeah, but is it better to have one? Mm-hmm. And I'll say, well, having one gives me a fuller picture of your whole situation. I use a lot of real-time ultrasound in the clinic, which is really useful, because I can then say, look, I can by proxy see what your pelvic floor is doing. So today, because you're not so keen to have an exam, I think I have enough information for us to go ahead and say, your muscles aren't relaxing so much, so we're going to start by reducing the contraction in them, switching them off, getting you connected to them a bit. And then we've got something we can measure next time you come to see if that's any better. If that's better, then probably we can get away without doing an internal exam.
Yeah.
But if I'm thinking, oh, this guy's really complicated, what I'm seeing on the scan is not really clear, and actually I'll say, look, I'm really confused. I'm getting equivocal information from you. Nothing is really clear here. So I'll say to them, so there's two ways we can work this. If I do an internal exam, that will save us a good number of weeks. But if you really don't want one, we can still work and we'll still get there, but it just might take a little bit longer, which is totally fine. And there's no pressure on you either way. The other thing that I've done is that I've developed a way of doing intimate assessment of the perianal area and all of the muscles that you can access externally to give some feedback. And that is often enough with the ultrasound imaging to tell me what I want to do.
That's awesome.
And I'll just say to them, I don't really want to be doing these on you, and you don't want me to be doing them on you. So if we can get away with it, let's not. Let's move on.
Yeah.
But equally so, I'll say, look, you're presenting in a really complicated way. If I said it might well be that I assess you today, and then that gives me a really good idea of how I can put a treatment plan in place. And it means I don't need to treat you internally once I've had that assessment initially to see where we're going. But it's definitely, I think when I started out, I had this idea maybe 15 years ago that everybody had to have an internal because that was the proper assessment procedure. Sure. And I've got way more comfortable at not doing it on them and just saying, look, guys, we're good. And I'll say, look, we can come back to this. We can revisit this. If in a month and a half, you're saying to me, I'm not happy with my progress, what would you like me to do? Would you like me to do an internal exam on you? in a way, what's happened is they've gained agency of that. They've absolutely taken on the ownership of that, and they've said what they want, and I'm just following their lead, really. Yeah,
I love that. Thanks for walking us through that, because it is. I mean, it's
tough.
It is tough. Yeah.
And I've had some people that I really think, oh, geez, I think you would do really well with some internal work, but actually they're just not up for it. And I'm like, well, yeah, that's it. They can't, if you're not up for it, you're not up for it. That's it. I always say as well, I say it because, again, global trauma informed, you say, it's whoever says no first. So if I'm doing some internal work on someone, I treat all of my guys lying on their back, eye contact. I want to see what their face looks like. I don't want them on their side facing away from me because I can't see what's happening. I have to. It's too awkward. Whereas if I'm looking at them, there's two things. A lot of trust, because they know I'm absolutely fine with what I'm doing. Then they know that I'm watching them. And if I think that during that they are having a traumatic triggered response to something I'm doing, I don't turn it into a big deal.
Yep.
I just say, I'm going to stop this.
Yep.
I kind of felt there that I'm going to tell you what I think. I think that that got a little bit hard for you, a little bit difficult. And I'm not sure if you shared that or if you felt that. Usually you get a few tears. Usually you get a few, and I'll say, listen, do you know, we all have things in our past that sometimes, because I'll say, look, you have you ever had an internal exam before? And a lot of the young guys never have. I'll say, well, and it might well be, we sometimes you have things in your memory that come to the surface, and who knows what they are. And then you have to really play it carefully, because it's almost a kind of a conduit or an opportunity for someone to say, yeah, I think I've maybe had some trauma when I was a kid, and that really has made me consider and think about what happened to me. And I've had some people that have done that and then gone on and done some therapy and done really well. And I've had some other people that have decided, nope, and it's gone a wee bit back into where they want to be, and they're okay with that. And it's not my job to push; it's my job to support, encourage, and guide. But I certainly wouldn't be. I think what happens with guys when you start training them, there is that big, you produce dopamine, and there's an intimacy thing happens. I don't think we talk about it very much, but there's a definite therapeutic intimacy that comes along. And they then sometimes just start talking. Mm-hmm. So I'm not a psychotherapist, psychiatrist, but I'll just listen. And if they seem at the end that they've talked that out and they're okay, I might say, you can do stuff about that if you want. And I have I have some sex therapists and I have some psychiatrists that I use. And I'll say, I can refer you to these people if you want to go and do some more work on that. Sometimes they then do the kind of slightly kind of more difficult thing and decide that I'm going to be their therapist. And because they're only going to talk to me. And we all get that. And I think I'm okay with that as long as I feel it's within my comfort zone and my sphere of practice. And I'm super, super careful not to provide psychotherapeutic advice. Mm-hmm. For me, it's more about, like lifestyle change, get active, reduce your stress, get outside. What do you like doing? Go do what you like doing, somatic snacks all day, like little easy things to do. Yeah. So I think that the other thing I would say with these guys, we were talking earlier a little bit about the diabetes thing. That is definitely getting more of an issue. Like I definitely see that more, people being a little bit, maybe a little bit heavier, carrying a little bit more weight. And I think it's like, EDs in diabetes patients, it's 35 to 50% of patients, wow. It's a lot. Again, it really doesn't happen. If they've got really uncontrolled diabetes or the diabetes is really severe, then that's worse. And so and the other thing that diabetes does, I don't want to even sound like a biochemist because I'm not, but the pathway, the kind of the complex pathways that change in diabetes, it impacts the synthesis of nitric oxide, which is one of the primary chemicals that actually allows erectile function to happen. So it's not just the vascular stuff, but again, you've got this direct function on a hormone that can make a big difference. So, and I think those things, although, I've spoken for almost an hour about things that aren't to do with physio, but, it's kind of like, but they are, it's because it's all about that. And I think for us, I suppose, like way back in, I think it was like Grace Dorey in I think maybe in 1995 was her first paper, but I think 2004, early 2000s, she did this randomized control study on men with pelvic floor, and she had 55 men with ED, not post-prostatectomy, for various things. And she looked at the effects of pelvic floor exercises. I wrote it down so I didn't get it wrong. They're combined with lifestyle change versus lifestyle changes alone. And after 3 months, she found that the group that were performing the pelvic floor muscle exercises experienced significant improvement in erectile function. And at 6 months, 40% of them had normal erectile function, and 35.5% showed improvements. And I like it because it's a really simple paper, and it was actually really well done. And it was very. But what about the 60% of guys that didn't? That's what I always think. I always read science papers and go, well, that's great for the 40%. What happened to the 60 that didn't get better? There was another systematic review, 2010, that showed that pelvic floor muscle increased erectile function by, in fact, enhancing the strength and endurance of pelvic floor muscles that support the erections. And I mean, it makes sense to me. It makes sense to us, I think, as functional pelvic floor trainers, that absolutely you need to do basic interoceptive brain connective thing. You need to bring the passive automatic function of the pelvic floor into the conscious realm so that actually guys can connect with it, because they have no idea. Although the nice thing about guys is they have spent a lot of time often touching, looking, holding their penises. So when you say things to them like, my big go-to is, if you want, especially if you're trying to get them to do anterior pelvic floor contractions, you'll say, listen, do you know when your penis was and is erect, you can make it bounce up and down? I never get a guy going, what's that? Every guy
knows.
I know that. I say, well, that is the front part of your pelvic floor, and that's the bit that we really want to get going. But I also think as well, but it's important to do the posterior component, because that's the other thing that helps lift and keeps the fascial tightness to keep the blood in the penis. And I think it's like there's some really interesting thing. If you with ED rehab, if you start doing pelvic floor muscle training, it really improves the whole quality of life of guys. Yeah. So there's evidence out there for sure. And I suppose the other group that we look at is now since PelviCon, my very, very good friend Jo Melios, who I've known for years. Just amazing to meet her. God bless her and her surgery. And I hope you're recovering well, Jo.
Aww.
So she did this amazing thing, started looking at incontinence and recovery prostatectomy. And she found this kind of she changed the position that we started teaching, that we teach guys to do for muscles exercises in. We got them doing them at maximum contraction, and we got them doing them doing quick. Now, her and I have a chat about this, because I think when we are teaching people to do fast pelvic floor contractions, we're not getting them to do them fast enough. I think by the time you say to somebody, and it's too late, and too late, it's too late. And if you look at strength and conditioning principles, you're looking at rate of force development. So if you're going to jump off a box, there's this peak of maximum force that you need to get. This is what my PhD is going to be about. It's going to be about how we apply these strength and conditioning principles functionally to the pelvic floor, because I think that absolutely we need to do that pelvic floor muscle training, that basic stuff, but we need to find a way of how we take that off the couch, out of the room, and into function, and then finally into sex and into it working. Yeah. I mean, it always reminds me a little bit like ACL rehab. To begin with, the guy's really focused on the knee bend and the squat, and at the end they're doing like plyometric light exercises all over the place, and they're not. And it's like I think we need to be doing ACL rehab techniques on the pelvic patients.
I love that.
Take their mind away from what they're doing so that they're not a 100% focus on that. And I mean, Jo's she did a study in 2020 that suggested that if you initiated pelvic floor muscle training early, it could really change the impacts of guys with post-prostatectomy. And I think that's what I see in the clinic. I use her protocol all the time, and I get some really good results. her and I were talking at PelviCon about where what's missing is that idea of functional training. It's like, and I think there's some evidence to drive it, because functional training will improve overall body function, blood circulation, cardiovascular health, which are all the things that, we need to do. The lifestyle changes are things like not so much alcohol, stop smoking, don't be so heavy, reduce your body fat. And I think you need an approach that integrates everyday activities to optimize pelvic floor training. I have this thing sometimes, like, we almost like shame women into doing their pelvic floor exercises, but saying, have you done them today? Well, no, because I was bloody busy.
Yeah.
I've got 3 kids and I'll work. And actually I haven't. I did them twice. We never say to some guys, have you done your knee exercises? And also, if you start to look at strength and conditioning principles, we don't take a muscle and go to the gym and work it hard every single day. We give it a rest. So my prostatectomy guys, especially, I will say to them, your muscles can't cope with every day. And I was really freaking out, because I thought, I'm going to get them to do this and they're all going to start leaking because they're all going to get really weak. And do you know what happened? They got stronger. They didn't actually get weaker because they had some time to recover. And I think the core, the lower body, because they're really integral for pelvic health and movement and stability. Again, we talked a little bit about mobility and flexibility, reducing tension, and then nerve function. The more you move, the more you've got this feedback loop where the more you're mobile, the more your nerves get all of that trophic chemical stuff to say everything. This should be healthy, and your muscles feedback to your nerves, your nerve feel, it's all kind of common sense stuff. And I think, absolutely, we need to do targeted stuff with posterior pelvic floor, bulbospongiosis, ischial cavernosus. That's important. Levator ani, all of that stuff. But I think that Kegels it's like women's pelvic floors are men and women's pelvic floors are at one and the same time, the same and different.
Yeah. Yeah.
But they're incredibly similar, but they're also incredibly different in the way that they work. And the big thing about guys is that they have this big long urethra and women have a really short urethra. You could say women don't have to ejaculate. Well, maybe they don't have to ejaculate sperm, but if you're looking at clitoral function and orgasm, some women do actually have kind of ejaculation. Yeah. So, there's a lot more, there's stuff that, again, like I said at the beginning, the stuff that we don't know, and I think we know a lot. And actually, like Carrie Boo's worked for years, and all of the guys that have created all that huge, great resource of pelvic floor muscle training and all that research that's fabulous. But we're almost at the next bit. Where do we go from here? What do we talk about? Loading the pelvic floor, intra-abdominal pressure. How does that work? How does that connect to intrathoracic pressure, which we never mentioned, but actually is quite important.
Yeah.
And how do we put all of that together? How do we functionally train that? And how do we move on from the idea that, just squeezing isn't enough? And I think for guys with erectile function, because there's a cardiovascular component, so aerobic training is super important. And, and like, you're young and fit, then it can be whatever you want to do. But I think, the best exercise program in the world is only as good as the patient compliance with it. So it has to be, you can say, I gave you this exercise program. I was watching an American hospital program and I loved it because the guy had cancer and he went back to see the cancer doctor and she said, oh my goodness, this is amazing. Your bloods are fantastic. And the chemo's really worked, and I'm so pleased with it. Well, it hasn't because I haven't taken it. I threw it away and I did supplement. It wasn't a real life thing, but I thought, there you go.
Yes.
We think it's the same. One of my pals the other day, he's got a shockwave machine and he was using kind of shockwave on some on MSK stuff, right? And if you ever had shockwave, it bloody hurts. It's not nice, right? It's uncomfortable. He said to me, he's a smart guy, and he said to me, I'm having such good success with anterior sin splint pain with the shockwave. I said, oh yeah, how what your outcome measurement? Oh, they just don't come back. It's amazing. And I went, yeah, I don't think that's an indication that they're getting better, mate. I think that's an indication that it's agony and they're not having it. So it's kind of awesome. I'm thinking it's funny that we make this assumption. And he looked at me and he went, Oh yeah, you're right. I think maybe I am. Go call them and ask them how they're doing.
That's
So
awesome.
I think that, core stability, hip mobility, exercises are things like plank, looks a bit like missionary position. Hip thrusting is what you do. Dynamic lunges is dynamic, like that stuff. It improves the posture, the nerve function, pelvic movement, really. I want to build muscle mass. Also, muscle strength training boosts testosterone levels. And I like really basic things like squats, deadlifts, and for the pelvic floor, deficit deadlifts, like going lower than standing a step and going lower, is really useful. They're really nice because they're almost like a dynamic stretch, but they also get some strengthening at the same time. And they kind of really, as well, feed into my kind of panicky obsession that we don't ever do eccentric training of the pelvic floor. When in actual fact, eccentric training is so important for every other muscle in the body, because it's what we need when we load. So we kind of say things like, so there's kind of an idea that if you squeeze your pelvic floor as hard as you can, and then you load it, that's going to be how it works. But it isn't how it works, because it contracts and then it lets go to allow the load to happen. So actually, way more than just squeeze. It's like control, rather than holding it all the time. And I think it's that thing about, we say with women, don't we? I mean, I've learned so much over the years treating women as how to treat men, because I remember things like, why aren't you allowed to jump on a trampoline? If jumping on a trampoline is the thing that gives you your symptom, we need to get you jumping on a trampoline at the edge of your symptoms. We need to find your 1RM. We need to find the boundary you work at, and we need to work you there. So get on the trampoline, but don't bounce so high.
Yeah.
Like, just let's find out how we get the load on it. Yeah, I think for me, people say, oh, does yoga help? I said, well, whatever you will do, whatever generates a feeling of well-being in you, if I say, it's like that old adage, swimming's good. And the patient goes, oh, great idea. The GP said I should go swimming. I said, did you go? No, I hate swimming.
Yeah.
So he never went swimming. He said, I don't like getting my hair wet. I went, okay. So, you say, well, actually, if you want to get better, you're going to have to get your hair wet. Well, it's not happening. I'm just not going to go. And I think for me, like a weekly plan for a pelvic floor, let's say I've got a young guy and he says to me, I want to do, he's a little bit uptight. So I've maybe got him doing yoga once a week, maybe twice. And that might be on his own. There's loads and loads of free resource on YouTube, on the internet. And some of it is really good. I've maybe got him doing Kegels maybe 3 times a week, but they're quite specific to sitting or standing. I've been experimenting with trying to get fast contractions. I get them to download a metronome, because the clip is that's how fast it has to be. It has to be that fast. It can't be and too late. It's dum 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 dum, and it can be dum nothing. Let everything relax.
Yeah,
nothing, because I think what we think is we have to get them all in a certain number of seconds. It's not about that. It's about the rate of force development. It's how quickly you can maximize that initial force that's generated by the contraction to make sure, with incontinence, that the pressure in the urethra is greater than the pressure in the bladder. And I think it's a little bit like that when it comes to ejaculation with these guys. When they're ejaculating, their muscles are contracting like that. They're not kind of going, squeeze. And so that all ties in with
so true,
isn't it? They don't kind of go, oh yeah, that's me. That's not how it works. It's like bang, bang, bang. The other thing I would say is that the thing about that I've realized is that there's this big difference between ejaculation and orgasm. And that sounds really ridiculous, right? But it's partly, and it was so I've got that experience being a male. You normally ejaculate when you orgasm. And you normally orgasm when you ejaculate. So if that whole thing is coordinated properly, now, funnily enough, if you ejaculate before you orgasm, we call that premature ejaculation, which sounds like a dysfunction, and it sounds like you're doing it wrong, and it sounds like you're really a bad sex person. Like you're not going to be good at it. And then again, we come back to that thing about, like I didn't even finish my thing I feel about that. Have you done your 10 squeezes today? Have you done your pelvic floor exercises? Well, no, because I'm really, really busy and I might do them tomorrow. And I'll say to my patients, and that is fine.
Yeah.
Have it off. If you are exhausted, all that's going to happen is you get stressed because you haven't done them.
Yes.
Which means tension increases through your body. You start breathing wrong. You start increasing your abdominal pressure. And funnily enough, you leak a bit more.
Yep.
Don't, it's this thing, we almost like make women, it's like, well, you're a bad woman because you haven't done your exercises. Now, absolutely, we know we can rehab women and make them better, but we don't need to shame them into it. We don't need to I get a little bit triggered when I hear people going, have you done exercises? I go, Jesus, like, leave me alone.
Yeah. So
I say to my guys, look, so talking a little bit about premature ejaculation, when guys sometimes get their erections back, there's a mismatch between the arousal level that they're in cortically and hormonally, and then their pelvic floor functioning and then actually ejaculating. And I think it's really interesting. I did a little bit of research on this because I suddenly thought, I've been saying this for a while and am I just making it up, right? But apparently there's this thing called, the duration before ejaculation is called ejaculation latency. And get this isn't a surprise. There's a significant variability between individuals, and it's influenced by genetic factors, neurobiological factors, and I think evolutionary factors as well. And it's partly because initially ejaculation was about maximizing or optimizing reproductive success. It was about getting the sperm to the egg, and it's definitely ejaculation latency. So how long you can last is variable. There's a genetic basis to it for sure. We know that. And it said, studies have identified genetic polymorphisms in the central serotonergic, dopaminergic systems associated. So it's quite complex, but it's there.
Yeah. Yeah.
It's saying that these findings actually suggest that natural selection might have favored certain genetic traits to optimize reproductive success. So guys that could ejaculate really quickly survived. So they could have sex with more people and they could deposit their sperm. So suddenly, genetically, what comes down through the ages is guys that can do this quickly. Yeah. The other thing was that it's if the female Homo sapiens would mate with more than one mate. So if you can deliver your sperm, she might go and have sex with someone else really quickly. But if you're much quicker, your sperm is in there faster. So yours is at the front and it's going to get in. And so you think, we don't even think about those things, right? Because it's completely changed. And then the other thing that was really interesting was about energy efficiency and risk reductions. Because it really, if you had prolonged sexual exposure, it meant that you were exposed to predators. And actually, you might well not make it till the end because somebody might eat you. And it wouldn't be her husband. It'd be a tiger, you know? And it's kind of like the things, it's like, but we think that the variations, they think anthropologically that the variations in ejaculation latency comes from that idea of enkephalins producing connection and loyalty. So that actually when women would become pregnant, the males started hanging around a bit more to help get food and look after the babies, which then that meant that whole family group would survive. And then the genetics that were connected with that would be passed on to the next group. And you think, well, and I just thought it was an erection. I didn't think it was that. But so I think that it's a nice kind of a roundabout thing to come back to that, in that I think sometimes guys think they're broken and sometimes they really think they're never going to be fixed. And I think the ejaculation thing is one of them. I think they'll say things like, premature ejaculate, priapism, hard flaccid, all those things are kind of on that spectrum of what's happening with your autonomic nervous system, what's happening with stress, anxiety, how are you relaxing, what's your environment like, what's the ecology like that you're trying to get an erection in. Some guy said to me, him and his wife were trying to have babies, and it wasn't really working, so he had to go and donate sperm. And then he came in to see me. We'd got his erectile function back, and he'd gone to the hospital, and he said, "Oh, can I take my wife into the room with me?" And they went, "No, you're just going on your own with a cup." I'm going to produce sperm that's going to make our child. I actually want her to be, and I thought, wow, I hadn't actually considered that before. He said, I wanted her in the room when I ejaculated the sperm that was going to make my baby. I went, I actually love that. I said, now I've started saying to them, ask them if you can go with them. Because he said, the first time I went, I couldn't do anything. I just went in this room and the woman said, would you like some porn? I went, no, I don't use porn. I don't want it. And she went, oh. And then he said, so I'm judged. I'm judged because I didn't want to use porn. What's wrong? I'm judged because I asked if my wife could come in with me. He said, and yet at home we would just have sex. He said, so there was just a bit that we needed some help with. And it was, in pelvic health, I think us as physios, I think we're amazing. I think we never do stuff like that. But I think, in the whole pelvic, the medical, the bigger, broader sphere of that, it can be quite a traumatic experience, I think, for our patients. So anyway, I think us as physios, I think we are, I don't know, we're kind of open to listening. The thing that I have learned to do I think that's probably my message, is that if you've seen thousands and thousands of patients, you're very, very quick to jump to, they tell you the story and you go, oh, I know what's wrong with you. You haven't got the data and you have to shut up and you have to go, I'm going to clear that out of my head. You're probably going to be right, but you want to do the process. You want to do where you get to the hypothesis, and then if you can't reject it, you have to accept it and you go, right, this is where we are, so that you're not just kind of we're just saying, oh yeah, that's what you've got. Yeah, let's move on. And that I think, irrespective of what's wrong with my pelvic floor patients, the thing that I hear again and again and again and again and again is, you were the first person to listen to me.
Yeah.
And you think as well, especially erectile dysfunction guys, you think it is just about muscles and squeezing and Kegels, and it is so much more than that. And recently I had a guy, he's quite a kind of erudite chap. And at the end of it, he said to me, he said, I just feel so much better. That statement, I feel so much better because now I understand. You listened to me. You heard my story. You gave me a sense of where that story fitted in with what I was experiencing. And that completely makes sense to me. I'm now off to change my life to make this happen.
Yeah.
And it was that, I think you said, how do you get guys to do this? Well, you don't really have to, if you heard and they feel heard, and you can, I always say to them, I will never give you an exercise that doesn't have a purpose. All my exercises have a purpose. I said, and you probably won't get more than 3, and then we'll review how that works for you. And I used to say that with all my MSK patients, because, I think we're brilliant, aren't we? We give people sheets of exercises and they just choose the ones they like and they forget the other ones. Or you say to them, I've given you this very specific shoulder exercise, and you're kind of showing them the exercise and they say, yeah, how are you? I'm not any better. Show me what you've been doing. And they go, I've been doing this. Yeah. I said, okay, I showed you this. Okay. It's like, and I think pelvic floor stuff is even a bit more like that. And so one of my little tips that I would probably leave you with is, it depends. I don't do it all the time. If I have a especially complicated patient, I get them to record the session and get them to take it away with them. And I'll also record so they can listen to it and come back to me with questions, because it's often too overwhelming for them to do the whole thing. And the other thing that I'll do is I'll get them to video their pelvic floor contracting on the ultrasound in the way that I want it to work. And I'll do maybe a minute's worth, and I'll have a little rest and do it again. And I'll get them to use that as biofeedback at home. And I think Biljana Kenway, a really amazing physio who lives in Switzerland, in Zurich, she actually did a research study looking at guys taking their own portable ultrasound machines home and scanning themselves and watching them. So I'm just doing it cheaper because these guys can't get a piece of kit. I just do the video and they watch it and they come and go, oh, that was so useful, because I could really feel the connection between my head and what my head's doing. And I think Joe's work of doing it and standing, I frequently get them to, if they're not really connecting with it, especially with the anterior pelvic floor, getting that penile movement happening and getting them to look at it in a mirror so they can actually see that that's moving. Because I think everything we do, I think in physiotherapy actually is about movement, whether it's joint movement, nerve movement, fascial movement, muscle movement, it's lung movement, diaphragm movement, movement. So it actually comes back full circle to pelvic floor physiotherapy is about movement. And that's where we end up.
Well, I think, gosh, I just love, I think that when we think about treating men, historically, the biopsychosocial aspect of it is overlooked because it's it's like way more mechanical. And so I think you just
100%.
kind of bringing that, like, because what I'm hearing through all this is I'm like, that approach is how I approach women. And given I don't treat as very many men, but I think that people listening to this, hopefully like taking away that it is that same, I think we override men's emotional systems when it's coming to this. So it's great.
100%. I totally agree. I think we need to give value and we need to give agency and credence to that. Like we need to just open it up. And sometimes that's tough for us because you might end up we all have our thing about someone in front of us having an emotional moment. And if you're not used to men in your life doing that, if that's not your experience, that can be quite tough. And, in Scotland, we have a bit of oh, come on, don't cry. You're all right. You'll be fine. Come along. And I'm more of there's a hanky. Crack on.
Yeah.
I've got plenty of time. Just you get it out, whatever you need. And I don't know what's wrong with me. I said, you don't need to. It's just good to have that emotional release. I said, crying's great. Do you do it much? You should practice. It's good. I say just gotta make it, normalize it, make it okay. Whatever they want to do. If they want to be uptight and angst about it, I don't pull it out of them. If they want to have that and keep it in, that's absolutely fine. Normally what happens is they'll come back and say, oh, you know what? I've really realized I'm walking about with my pelvic floor tight all the time. I'm so uptight. And I'll go, so what do you do? What tools do you have to address that? And they go, what do you mean? And I'll say, well, okay, so listen. And I just take it back to, I'll say, look, there's one of my favorite chats is there's no such thing as anxiety, right? It's a social construct, right? It's what we've invented so they can give you a pill to reduce it, okay? But in actual fact, it's physiology. It's in your body. It's your fight, flight, and freeze response. It's your autonomic nervous system either overworking or not working enough or being disconnected or dysregulated in some way. And you need to get back to regulating it. And there's a whole bunch of things that we can do, like breathing and movement and exercises, mindfulness, connectedness, somatic snacks. There's a whole bunch of things that we can do. And Carolyn Van Dyken from Canada taught me this thing about, and it's such a simple idea and it's just brilliant, like kind of consumer comparison. So you do something, and then once you've done it, you go back into your body and you go, is that different? Has that changed? I don't need you to tell me what it is, but is it different? And is that different good for you? Has that made a change for the better? You don't need to actually work it out. It's like the whole, Hessel van der Kolk's book, The Body Keeps the Score. 100% the body does. And it doesn't just keep it, it holds on to it. And it sometimes decides on the score what it's going, on the basis of the score, how it's going to be. And so sometimes just learning to let that go. And with guys using HIIT type exercise, intense exercise, short burst stuff, breathing, loading, weights, all of that stuff really can make a huge effect physiologically on anxiety. Because for me, anxiety is kind of one of those things that you think you have no control over. You can't do anything about it. But in actual fact, if you can change your physiology, then the anxiety slowly goes away. And it's not that easy, but you practice and you practice when you're not feeling anxious. You practice it when your symptoms aren't there. And then you try to put it into play when you might get into a position. It's funny because I had a patient recently that I was kind of supporting through a fairly difficult kind of flare. And they were saying to me, we were kind of communicating by WhatsApp. And then I said, so I'm going to withdraw my support now because I actually think I'm enabling you. Okay. I said, I'm going to be really clear about this because I actually think what I'm doing is actually producing your anxiety. And she said, so you have to be careful about that, because so I was saying the right things, but I said, yeah, okay, so this isn't working because in actual fact, you're spiraling. I said, so I'm going to give you an anti-spiraling kind of technique. And my technique I use for that is, you imagine you've got a big spring and you're falling down the spring. And I want you to throw a plank underneath, in between the spring, so you land. And it bounces a bit. And you look around, you're in the spring, but you're not spiraling anymore.
Yeah.
I said, then you get some friends or some lovely people to come and see you, and they start spinning the board, and you go back up the spiral, and you do it yourself. And I said, so that's my one thing I use. My other thing I use is, and I stole this from one of my psychology colleagues that I work with, and I love this. I'll say, so you take the pain, the bladder symptom, you take the thing, the issue that's really winding you up, and I said, you blow it up into cinema size, and you make it really brightly coloured, and you look at it, and you go, wow. I said, and then you take the colour out of it, and you make it black and white.
Yeah.
I said, then you shrink it. And you make it smaller and smaller and smaller. I said, and then you turn it into almost like an old-fashioned photographic kind of one of those, what's it called? It's so long ago I've had one, I can't remember what they're called. The image, you take a picture and then you get the negative.
Yeah, the negative.
Negative. Yeah, we all have digital. Who does that anymore?
I know.
So you have like a negative. And then what you do is you make the negative become really crumbly and disappear in your hand. And so when you actually squish it, it's just dust.
Yeah.
And the wind comes along and blows it away. Now, and of course, what that does is it takes your mind away from the whole thing that you're focusing on. But it was interesting that although I thought I was actually helping her, I kind of was quite quickly realized that I was actually just enabling her.
Yeah.
And then so I just said, okay, I'm going to just shut down this path of communication, and we'll check in on Monday. So you have a whole toolbox of stuff to do. I want you to use your tools. And then on Monday, he sent me a message on Monday saying, you were right.
I love that.
But, I think that's an important thing, is that we aren't psychologists. We might have some skill in that area, but you do have to be careful, because I was getting a little anxious about I felt a little bit overwhelmed with that. As soon as I felt I'm actually outside my comfort zone here, I'm going to stop that. And I did suggest, I said, I think perhaps having had this experience with you, I think you need some extra help, and I can't give you that help. Yeah. You need to get that from someone else. So we're going to draw a line here. And that's quite hard. I think especially for early career physios, that's quite hard, because you kind of suddenly feel you're kind of getting you start drowning yourself. And I think that's one thing I would say maybe is, it's a tough gig, pelvic health. It's amazing. It gives you so much back. It just makes you, I don't know, it's the area of physiotherapy that you really feel you can make a huge difference in people's lives. Mm-hmm. But it is really, really hard, and we have to look after ourselves. And I think if you're a female, maybe some of the female physios thinking, I want to treat men, but I'm a little bit worried. Mm-hmm. I think that's okay. To be in that position. So start from that position and make sure your safety is absolutely paramount. So I sometimes get physios saying to me, this happened. I'll say, okay, that is not acceptable. Right. If you're asking me, was that okay? It's about your safety every single time. So if that means having a chaperone, if that means I'm always a little bit concerned perhaps if women are sole practitioners and they're seeing men, because I think, wow, that not every man is going to be attacking a woman or doing a horrible thing to women, but it's an increased risk. So I'm kind of really, I'm kind of passionate about making sure that the patients are safe. It's not, and the physios are safe. Yeah. And I think we need to call it sometimes, and sometimes it's just interesting. I'm super lucky. I feel like I have to touch some wood. I've been doing this for 25 years. I've never had an incident where a patient has ever been uncomfortable with what I've done.
Yeah.
I've had a couple of incidents where I've been uncomfortable with a patient, and I've called it. And I think that's another awareness thing. One of the things I would say I do, which is, I don't know if it's very common, but I have kind of like a supervisor that I go speak to. about the stuff that I see at work, because I do get a lot of trauma patients, and I find that really useful. It keeps me kind of fresh. It kind of keeps my head clear. It means that I'm not kind of sucked into things that I feel are outside, because I think that we do often feel that we think we can fix everybody, don't we? And we can't. And sometimes it's really hard to go, oh yeah, I don't know if I think this might be outside my comfort zone. And I think it's important to stay safe, to give our patients the best they can, but we have to be there to treat them the next day. So we need to look after ourselves as well, on a day-to-day basis. Yeah.
And I'm glad you touched on that, because we know that the male population is very underserved in pelvic health, and because it is, and being a dominated field with mainly female practitioners, and that is a hesitation. And so that was one of the things I was going to ask you if you had advice. And so I think it's great.
And I think, well, you just make sure that for one of the things that happens, and I'm super lucky because I have a big practice and I have a receptionist and I have people that these guys meet before they come to me. So that, in your sense, it opens everything up.
Yeah.
They actually sign, and when they come in, they do a thing where they'll have filled in a questionnaire. They know what they're coming for. They'll have signed a general consent form for physiotherapy, but then I'll specifically talk to them about the consent and make it really clear. The other thing that I say to them as well about consent is, although you signed the form, that's not the important part for me. The important part is, how are you feeling during the whole event? Yeah. So I will call this at any point that I think you're uncomfortable.
Yeah.
But equally so, I think absolutely, quite rightly, patients' well-being should be up there. Yes. But so should the physiotherapist. And, we do want more people treating men. So we need to make sure that the people that are doing that feel safe to do it and feel supported. Yeah. And I've heard some not very nice stories about female physios having had very unpleasant experiences with male patients. And my feeling is that you call it as soon as you think it's not right. And do not second guess yourself. If it does not feel right, it isn't right. And that's it.
And that's it.
And I just go bang. And I think you say, and you know what, you immediately become, I think what happens is there's a vulnerability in this work. Like it can make you feel a bit vulnerable. And there's a thing about, we all bring our own baggage to the clinic. And even though we try to be professional, sometimes the shock of someone acting a certain way to you gets through that barrier. Mm-hmm. And I think it's really important to be, again, this sounds like a bad thing. You just assume globally that everyone's going to be not to be trusted in a way. Yeah. So you just say everyone's the same. I just assume I'm always going to be. I want to minimize my danger. So I want to minimize any threat to me. So if there's ever anything that I feel is uncomfortable or not right, then, and the thing is, it might well be because these guys have had a lot of trauma. So it might just be a trauma response that they've had to the situation and they mean nothing by it. Yeah. But the problem is, if that makes you feel a certain way, that's the end of it. Yeah. You cannot put yourself through that. So they need to find another therapist, or you need to help them find a therapist that isn't going to have that response to them, if that's all it is. But if it's that they're actually, like going to behave in a way that's just not acceptable and inappropriate or dangerous to the therapist, then that's you just draw a line. Yeah, for sure.
Wow. So much. I have like pages of notes that I took, even though I can go back and listen to this. So good. Roxy, do you have anything? I know you were jotting down as you go too.
No, I'm same. I need to review my notes, I think, later. But Bill, Bill, do you have any just like final send off of just summarizing in a nutshell, or I don't know, do you have just a final thought?
Men really need our help. That's one thing, right? Yeah. There's not enough of us supplying that help. And I think get yourself someone that can mentor you and can support you and feel that you have somebody to ask questions about treating men. I think as well, get yourself on a course that explains Holly Tanner's course about how to drape, how to assess and touch penile tissue and testicular tissue. I have some. I'm pulling together some notes about that I'm going to kind of make freely available, because I think that like how do you drape a penis? How do you move it? How do you not move it? Do you get them to move it? All those questions about. So I think go and shadow someone that's treating men. Go and see someone that sees a lot of men, and see what they do. But I think for me, it's probably about getting. When I started this, I was really lonely. There was no one else around me. So get your tribe that you trust and stick with them, and make sure that, as well as sharing, there's kind of supporting. Don't put yourself in any situation that you're ever uncomfortable with, ever. I think that I think the whole safety thing for me is just paramount. Like I can't really emphasize that enough. Obviously, but at the end of the day, treating men it's good because they're underserved and they're so grateful. Yeah. And they're so grateful. And actually, the other thing I would say, I liked what you said, Megan. You sometimes don't need to do very much to get quite a big effect. You don't need to do all of the internal work to get a big effect. You can sometimes, by changing all their lifestyle, getting them moving, reducing the stress, all of that stuff, that can sometimes be enough to put them on the path of recovery. It sometimes seems a bit daunting, but if you're already treating women, you're halfway there, if not more than halfway there. And I would say, go do
it. Awesome. Well, Bill, thank you so much. This was so much amazing information. And we know that not only other pelvic floor therapists are going to take a lot from this, but also just, patients listening. And we hope that, if anything, if females are listening to this, that their husbands are going through something, passing it along, so that we can increase awareness that we're here.
Yeah.
Physios in the pelvic health space have a place to help treat these things and have really great outcomes. So, gosh, we just can't thank you enough. And we're both really excited to connect with you again in person at PelviCon again this year in 2025. So we'll do the plug for that.
It's been good fun. I look forward to September. It'll be good.
Yeah, it'll be such a good time. So thank you so much.
You're very welcome. Thank you. Thanks, Roxy. Thanks, Megan.
Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.